All right. Thank you guys for joining us tonight from wherever you're at. I hope you guys are somewhere comfortable and enjoying an adult beverage. My name is Art Lee. I'm an interventional cardiologist. I practice in Gainesville, Florida. And tonight I'm joined by two good friends of mine, Ian Kawich and Prakash Krishnan. The topic tonight is titled Prevalence of Arterial Thrombus and Need for Atherectomy with Aspiration. So here's the faculty, like I just said, and you can see the titles. Ian is practicing in Little Rock, Arkansas. Known him for a long time, a lot of experience with atherectomy, done a lot of studies, and he's the medical director at the Vein and Vascular Institute at Arkansas Heart Hospital. Prakash Krishnan is the director of endovascular services in the Mount Sinai healthcare system. You can see he's associate professor as well. And I did some of my training at Mount Sinai, so always great to see PK. And then myself, Art Lee, in Gainesville, Florida. All right, here are disclosures. I'll just leave that up for a second. And this is, a CME program provided by NACME, so the North American Center for Continuing Medical Education. It's supported by an educational grant from BD Peripheral Intervention. So objectives tonight is really, learning to identify an arterial thrombus. And I think that definitely, sometimes we learn the hard way, but it's probably under-recognized about how much, arterial thrombus there is in our daily, lives and procedures. We're here to determine the best course of treatment based on the thrombus morphology and understand the different types of atherectomy and the respective applications. So without further ado, I'm going to hand it off to Dr. Kawich, and go ahead, Ian. Thank you.
All right, thank you, Art. And like you mentioned, we tend to, this topic is going to talk a little bit about how thrombus formation occurs and a little bit of how we underestimate some of the thrombus. So if we can go to the next slide. So, the presence of thrombus, associated with either prolonged procedures. We've all been there where, we didn't appreciate the amount of thrombus. We embolized. We're in there for a few more hours than we anticipated. There's more contrast use when you have thrombus, have greater radiation exposure, and then obviously a higher incidence of adverse events, especially and including distal embolization, which is the main topic. Next slide, please. So as what we see is that we don't only deal with active thrombus, we deal with chronic thrombus. And as thrombus ages, it becomes more organized, and with the ingrowth of smooth muscle cells, connective tissue, and capillary vessels. And then the more organized the thrombus, the harder it is to dissolve and remove. And so what we see with the thrombus formation is that we initially have this plaque rupture. And when you have this plaque rupture at the cap, then you have activation of the coagulation cascade, you have platelet activation, you have platelet aggregation, and ultimately you have this thrombus formation. And this is initially how it becomes with you having, active acute thrombus, and then that eventually develops with the smooth muscle integration to the chronic thrombus. And so there you see the schematic where it described it a little bit, how the cap ruptures the thrombus, the initiation of the smooth muscles and the necrotic cores. And so histologically, what this shows, next slide, please, is that when the rupture is correct, is characterized by the disrupted fibrous cap, then you have that thrombus formation, and what you see is that underlying necrotic core. And then the thrombus can actually consist of calcified nodules as well as some incorporated fibrocalcific plaque. When they evaluated, some of the arteries with more than 70% of luminal stenosis that had been amputated, they saw that in the fem-pop area, there was more atherosclerosis present than in the infrapopliteal areas. The infrapop arteries had higher incidence of chronic thrombotic occlusions compared with the fem-pop arteries. And that CLI mostly involved a lot of thrombotic occlusion of the peripheral vessels. And the calcific patterns were also different. The distal tibial vessels throughout the plantar circulation were different. CLI involving tibular and plantar disease, still is one of our biggest challenges. And I think later on we'll have a couple of, presentation cases where we show that, the tibular and plantar disease is one of the most difficult to treat. So when they looked, when Narula looked at the characterization of the large arteries for CLI, they saw that, peripheral plaque morphology was typically heterogeneous, and that 73% of the stenotic plaque lesions included either some acute or chronic luminal thrombi. 20% of the stenotic lesions didn't involve thrombi and were mostly made up of intimal thickening, fibroatheroma, fibrocalcific lesions, or just neointimal hyperplasia or restenosis. And so again, you see a schematic of where the FemPop, most of what the thrombi that they saw was mostly acute, as with mostly atherosclerotic plaque, whereas in the infrapop, you had more of that chronic thrombus formation and still having some acute thrombi, but mostly chronic thrombi. And so the potential impact of this thrombus, can be significant. The thrombus formation also causes secondary thrombotic events. You have other effects like the limb event, some limb events such as acute limb ischemia leading to major amputation, more limb revascularization, symptom progression, and then obviously ABI and TBI changes. Also, you had other increased cardiovascular events such as myocardial infarctions, cardiovascular death, and then heart failure. So what Zeller looked at was the embolic capture of after interventions in the lower limbs. And so the characterizations of lesions were collected. All the embolic capture was after not just balloon angioplasty, but after atherectomy use, aspiration and stent use. And, the histologic, it was, what they saw was that they saw thrombi or captured material in 100% of the devices used. And the majority of the thrombus that they found was in lesions that were not always angiographically identified as being thrombotic lesions. And so the majority of the lesions, what most of the embolization in the cases that they saw were in lesions that they felt were thrombotic, but not all the lesions were characterized as thrombotic. And so they looked at the variable lesion types, iliac lesions, popliteal lesions, SFA lesions, long lesions, de novo lesions, restenosis, and ISR, and then different calcification levels. And what they saw was that when they looked at the lesion, only 8% were identified as being a thrombotic lesion and 92% were felt to be non-thrombotic. However, when they actually looked at the captured material from that, they saw that 52% of the captured material was analyzed to be thrombotic. And so although they felt that the initial lesions, only 8% of them had any significant thrombotic lesions, actually most of the captured material was thrombotic. And so we tend to underestimate the amount of thrombus that is present in plaque. This is different than when you have calcium, which, in the lesions analyzed, they felt like 89% of them were calcified. However, when they looked at the captured material, only 3% of the captured material had any calcified component. And so again, as far as embolization, the calcium is often overstated as far as what embolizes.
Yeah, Ian, I just want to make a point. I think there's two ways to interpret this data. One is that we're not real good at describing or predicting, when we see a lesion that's either not thrombotic or calcified, or the other way to interpret is that even when it is very calcified or non-thrombotic, there's this, when things do embolize, it's the thrombotic component of that plaque, right, that embolizes. So I think that's important.
No, and also, Ian, I think this is great because building on what Art said, without a question, we looked at our data in Sinai and looked at embolization with filter, and we published that in JACC Interventions about, 4 or 5 years ago. And the interesting thing was that, when you had 3 experienced operators look at this stuff, majority of the time, all of us will say that, okay, if your wire flies through, then likely it's thrombus, right? But what you're showing is that even atherosclerotic plaque has a thrombotic component. And I think that's building on what Art said. I think that's incredibly important because angiogram is definitely not something that's going to allow us to really look at that carefully and make a judgment. Maybe like, and we were talking offline, maybe IVUS or OCT might help us to do that more. But I think this data should really open the eyes of the audience to really say that, hey, you know what, we may not be sure what we're looking at, and that, thrombus is probably, not possibly, part of our intervention during this particular procedure.
Yeah,
both great points by you guys. We tend to, based on fluoroscopy, tend to overestimate and underestimate different things. Calcium, fluoroscopically, we're more likely to identify it, but compared to some other modality images, it may be underestimated. The same thing with thrombus. We a lot of times, like you said, we all have that feel of the wire that, the way it crosses, that we can judge how much thrombus there is. But, having quite a bit of experience with OCT crossing devices, we tend to see a lot of thrombus present, even in areas that are heavily fibrotic and heavy and difficult to cross. There's still quite a bit of thrombus present in multiple areas. And so, it's one of those things where, as both of you guys pointed out, we're not very good at telling what's there and what's not. We're good at guessing what's there, but objectively, I don't think we need some more analysis with either OCT or IVUS.
Yeah, no, I agree. I think a point, I don't know if there's fellows out there or new people. I mean, I think the way your wire and catheter cross are key. I mean, unfortunately, again, I have OCT and IVUS mostly in peripheral lab, but it's at our disposal. We have, the OCT crossing devices. I don't use a lot of that, but I still think that reliably, I think OCT, you can tell if it's thrombus. IVUS, people say you can tell if it's intraluminal, but I personally don't think you can really tell reliably. And so, when you don't have a reliable way to know, I mean, I think the way the wire crosses and the catheter crosses is really important, when it crosses fairly easily. And even when it's not super easy, but it crosses, prolapse wire, catheter, and you get through, I think you have to almost presume there's thrombus and this mixed morphology plaque. And therefore, as we get, culminate to sort of the atherectomy devices, that I think that's important in your choice of atherectomy devices. So, yeah, I think those are great points. Okay, sorry, Andrew.
And also,
I think one more to your point, where you're describing how the wire feels. We have all that area where the wire will buckle, or the wire, you have to use finesse or change your wire type. But we also have in between those long segments where you'll have where the wire moves really freely, and then you hit your next point again. And so, it's that mixed morphology that, we sometimes don't pick up on. That we're excited about crossing with the wire and forget what's actually the components made in the total occlusion.
Right, and also Ian, building on what Art said, is that earlier, if you have an embolic event, it can be catastrophic. A calcified event, always gives you a chance of recovery, in the sense that, okay, you do a balloon, you have a dissection, you pretty bad dissection, you can put a stent. You have recoil, you can say, okay, I'm going to do another procedure to expand the lesion. But if you misjudge thrombus, and I think that this is a very important point, is that if you do shower emboli, now you've taken a quote unquote easy procedure and now made it a very complicated long procedure as you go and bail out below the knee, using lytics, et cetera, et cetera. And I think this data that you're presenting really highlights that aspect that to keep in mind. And I also really like your point, which I always teach my fellows, is the mixed morphology, because you always have the proximal cap that you fight through, and all of a sudden you have this long segment lesion, and then you have a distal cap that you fight through, but the mid segment you have no problem, and likely you have this hibernating collateral that's feeding some sort of blood in there, and you get this mixed morphology plaque and thrombus that your wire glides through, and you tend to forget about that, and then you balloon angioplasty and bang, you've got all this embolization. So you're absolutely right. I think it really is very important to look at your behavior of your wire as you get through these long lesions.
Yeah, just one of the audience people asked what de novo lesions meant. De novo lesions are just lesions that haven't been intervened upon previously, so new lesions, not in-stent restenosis or restenosis. Okay, go ahead, Ian. Thanks.
Good. No, very good points. Even Christian, and even PK's point is well it's something that should be highlighted for the audience that, taking something easy, the success of crossing and then embolizing and spending, another couple of hours, trying to regain, flow down in the distal vessel is probably one of the operator's worst nightmares.
That always happens on a Friday afternoon when you're trying to get out of town too.
All right, next slide. So speaking of, distal embolization, which, is the complication that one of the most complications we fear the most as operators. It significantly adds to the case time, it used to the resources, so it's, there's what they've seen is, obviously there's, when they looked at what, distal embolization, what are the increased risks for them, you had high risk scenarios, so as long occlusions, especially because of that mixed morphology that we talked about, single vessel runoff, because, again, if you embolize to a single vessel, that then you have no flow and you've taken something that may have been a chronic symptom and made it now into an acute limb salvage, limb ischemia symptom situation. And then obviously, it's been shown that, concomitant use with atherectomy devices, have those, increase the risk of distal embolization. In my experience, what I've felt that, in the last decade of practicing, especially below the knee, I've found myself using more and more filters because of distal embolization. One of the things that I always think of when I'm doing a case is if I think, should I be worried? Should I put a filter? That's my answer. If my question is, should I put a filter? My answer is I should put a filter, simply because I know that the distal embolization is as far as what you may call a catastrophic event, because then you have to go treat below the knee, whereas opposed to just you could have treated the SFA. And what they've seen is that, sometimes, it requires, distal embolization requires additional endovascular treatment and then even open surgery in about 11% of the cases in some studies. It was distal embolization was more common in patients treated for critical limb ischemia compared with claudication. And there's more evidence seen in emergent interventions as compared to elective interventions. Increases with the number of arteries treated and with the length of the occlusion. And patient with distal embolization had longer procedures time. As we talked about, it was especially with significant higher fluoroscopic time and more contrast use and longer hospital lengths of stay. And so in conclusion, we discussed that, PAD has a heterogeneous morphology. Thrombus in PAD is more prevalent than initially perceived. Thrombus can lead to secondary negative outcomes. And then distal embolization is a preventable adverse event. And then part of this, talk is that, there are tools that can easily adapt to variable plaque morphologies, and those are needed in our space to try to prevent some of the things that we discussed.
All right, Ian, thank you. Thanks for that talk. So good conversation. Okay, let's move into PK's talk about choosing, what the different atherectomy devices out there are and how to potentially choose them based on patient and lesion. Thanks, PK.
Thanks so much, Art. And, Ian, fantastic overview of what we all know is true as operators dealing with these complex diseases. And I think you really highlighted, Ian, the points in a very clinical manner, which I think is what's really appropriate more than in a pathological manner, and how it affects, our day-to-day practice. And, whether it's time in terms of our ability and the cost of the procedure, and obviously, most importantly, the patient morbidity of exposure to contrast, excess radiation, and how important the recognition of this particular lesion morphology is very, very important. So I really congratulate you on that. So, I think just building on what Ian was talking about is that, we need to look at the lesions, okay? And we need to understand the lesions where they are. And above the knee, as you can see by this survey, really from Viva, really published in Bishop in the Annals of Vascular Surgery, looked at lesion morphology above and below the knee. And the reality is all lesions are not equal, okay? And I think Ian showed that. The majority of the lesions above the knee are mixed morphology, meaning that there are multiple plaque types with the presence of thrombus, really looking at the morphology because of the length of the lesion changes as we do. These lesions tend to be larger, meaning the vessel diameter tends to be 4 to 9 millimeters. And they're a mix of calcified lesions, thrombotic lesions, and obviously CTOs. Below knee, the lesions are more commonly calcified. They're more tortuous, challenging anatomy, and the vessels are also smaller. And generally, we're dealing with obviously a percentage of CTOs below the knee, but the majority of our lesions are really calcific or fibrocalcific lesions, and this has also been shown by IVUS. Next slide, please, Art. So the challenges really of these lesions are really recoil, and this may be due to the underlying calcium, whether you're above or below the knee. And most of these vessels undergo significant recoil following angioplasty. Okay, 97% of lesions had greater than 10% recoil 15 minutes after POBA, and 29% of vessel recoil occurred after POBA. So basically, this is because we're unable to really look at calcification, really understand the impact that this particular vessel has. Next. So let me look at the tool that we're here to talk about is really atherectomy. And atherectomy in dealing with really complex lesions, because whether you're looking at either complex calcified lesions, complex mixed morphology lesions, or complex thrombotic lesions, you need to use a particular device, a particular arrow for that particular target that you're trying to hit. So you are lucky enough in America to have a plethora of atherectomy devices that are available in our armamentarium. So some of them that are available, I'll just go over each one, is you've got the Diamondback Diamondback, and then you've got the Hawk 1 Turbo Hawk. The peripheral rotablator is still available for below knee for peripheral use, laser atherectomy, the Phoenix atherectomy, as well as the Jetstream. And then, of course, the newest member of the American block is the Rotarex. Next. So when you look at the data available with atherectomy devices, you've got I wouldn't say a plethora, but you've got enough data really available for you to kind of understand the limitations of these particular devices. You've got certain studies that are core lab adjudicated, certain studies that are really procedure reported and operator reported. But in general, the directional atherectomy, I would say a cohort of the data that's available has probably the most robust data that's available in terms of lesion morphology, lesion dissection grades, and 30-day major adverse events. Next chart. So here's one trial that actually looked at atherectomy and drug-coated balloon angioplasty in treatment of long infrapopliteal lesion, the ADCAT study. This is basically a look at the TurboHawk study using Lutonix for long atherosclerotic BTK lesions, which is interesting because below the knee right now, we don't have any really viable drug technologies that are currently available in the United States. Next, please. So what they looked at was they looked at multi-center randomized data, atherectomy plus DCB versus DCB. And the major reason I think they looked at this was kind of what Ian was talking about, the mixed morphology lesions, thrombus and calcium, and whether or not we can prevent dissections and recoil. The number was a small number of patients, 50, and about 10 European sites. And this is a slide shared with me by Dr. Zeller. So the Rutherford 3 to 5 BTK lesions, they looked at Diamondback, and as well as Bard Lutonix 014 DCB. And the primary endpoints were technical success, less than 50% residual stenosis, procedural success, and device success. And the treatment success was defined as percentage of target lesions meeting technical successes, less than 30% residual stenosis post-DCB without adjunctive therapy, which is very important. Next. 800 patients, you can see here, they did have a smattering of claudicants and CLI, about 600 to 200. And the primary patency was in the claudicant arm was freedom from, duplex patency at 12 months, and CLI was freedom from major unplanned amputation at 12 months. Next. And again, this is just the data, it's beyond the scope. Next. And you can see here that the primary patency clearly was improved in the atherectomy plus DCB arm, and as was the freedom from TLR. So clearly showing that atherectomy played a role in terms of preventing the recoil as well as preventing the restenosis. Next. So if you look at other significant data supporting atherectomy, if you look at the definitive LE 12-month outcomes in the CLI cohort, the atherectomy, it was a single arm study, but if you look at atherectomy, you had complete wound healing in 72% patients. 94% limb salvage, 87% freedom from TLR, and a 78% primary patency in the below knee cohort. Next. And again, just to go through some other different atherectomy devices, you have the Diamondback system. I know it's available here, and you can see you have multiple different sizes depending on the type of lesion that you want to use. Next. And you can see with Diamondback, obviously the entire idea would be to reduce the maximum balloon pressure that you need to dilate the lesion, thereby preventing dissection, thereby preventing bailout stenting, and thereby preventing restenosis. Next. So if I was to just sum up things and really talk a little bit about atherectomy and lesions, and I think this is where I'm really going to need Art and Ian to help me, is that if you look at thrombotic lesions, right? And I mean, I kind of did this rudimentarily to say that, okay, you have identified thrombus. You know it's thrombotic from a clinical presentation or whatever it is. Somebody tells you that, hey, my leg felt great a day ago. Last night I was sleeping. Now I feel terrible. They call you up, likely it's thrombus, okay? So your defined thrombotic lesion. I thought at this stage, obviously what most people would do is either aspiration and local lysis at the level, maybe leave do an indwelling catheter and then bring the patient back 24 hours later. I wanted to talk a little bit about Rotarex, which we'll hit at the end of this, which I think is really a game changer in thrombotic lesions, at least in our hands at Sinai. Phoenix atherectomy, we've had mixed results with it, made basically because of the Archimedes screw gets very clogged up in these particular types of lesion. Laser has been, all the conferences that we attend, everybody talks about it as a possible, or a great device in thrombotic lesions. We personally had mixed results in it. Jetstream, we've embolized, had massive embolization with in thrombotic lesions. So therefore we tend not to use it in thrombotic lesions. So this is one. But before we get to the discussion, I just want to go with fibrotic lesions, because what Ian talked about was that even in fibrotic lesions and calcified lesions, you have a spattering of thrombus. So in these particular lesions, we in the fibrotic lesions, we really kind of defaulted to Rotarex being our number one therapy, because I feel that because of the aspiration aspect of the Rotarex and also the ability for it to actually debulk the lesion, I'm getting the most bang for the buck in terms of the most effective therapy without having to do adjunctive imaging or anything like that. Directional atherectomy still remains part of our armamentarium, but more and more rotational aspirational atherectomy has fallen off because of, number one, the sheet size, and number two, obviously the embolization. And laser, we've never really been proponents of that. Calcified lesions, below the knee, clearly high-speed rotational atherectomy, really with the Diamondback CSI remains our go-to. However, Rotarex above the knee, and especially in the Popliteal lesions, and I'm curious to see what your opinions are right after this slide, in terms of us at Sinai, we are starting to use it in calcified lesions. I didn't want to talk about ISR because it is off-label, but I'm curious on the two of you. How about you, Art and Ian? What do you guys do in these types of lesions? What is your algorithm?
Yeah, no, I think this, can you hear me? I just want to make sure. Okay. Yeah, so I think this is a great summary, and I agree with you. The data on atherectomy is pretty poor, honestly. 30-day outcomes, 1-year outcomes, it almost doesn't matter at that stage. I mean, you want to make sure it's safe, obviously, but in terms of effectiveness, for any therapy in peripheral, I feel like 2-3 years is really going to become the gold standard in head-to-head studies. But I think this is a good summary of what you can use, and I think it all depends on your experience, local representation, support for the cases, experience, et cetera, et cetera. So I think it's a good summary. I definitely think that in terms of thrombus and mixed morphology, so I almost grouped thrombotic and fibrotic in that category. I've actually fairly recently started using Rotarex and been very impressed, and that's probably the reason I'm here, is that Rotarex has basically become my sort of catch-all device when I'm not sure what lesion is in there, what's in that lesion. I'm going to use it because I think that thrombus is what's going to really get me in trouble during that case. And the other question that you had was calcium. So it's usually thrombus or calcium. Those are the two big issues that give us a hard time. When you have a calcified lesion, a lot of times I use Diamondback. But like today, I had a lesion that had serial occlusions, but there was also 2 stents in the proximal distal SFA. And my wire went through fairly easily. And even though there was a lot of calcium, I actually brought the Rotarex in. because it's a complete occlusion. Now, if it was 95% stenosis and calcified, I'd probably go CSI. But what I find myself doing is if I have a total occlusion and I'm not sure and my wire goes through fairly easily, I'm going through Rotarex. And in this case, there were some really calcified areas to the point where the Rotarex actually decelerated. There's a magnetic sort of clutch where if it catches anything, it basically disconnects. So when I got that, I would back it up and I just go slower. There was, some lesions where I actually went through it, past it, and did the rest of the vessel and just didn't do that area. And it worked pretty well. So I think that, definitely calcium, I think about CSI, but I think Rotarex, you just got to take it case by case.
What about you, Ian? Anything different?
No, I think that your slide, highlights very well how, our options that we have. When I think of our, the data you presented as far as outcomes, we don't have a lot of good long-term data to show, how atherectomy, benefits us. From one of the things that, in my standpoint, I think when I see a lesion or when I'm treating a lesion is I think of, well, what do I want to do? Do I want to cross this 30-centimeter chronic total occlusion and just, full metal jacket it, just put a stent in and just full metal jacket it? Or do I want to, do something that maybe I don't have to do as much further adjunctive therapy, especially talking about stents? Or, if we have an off-label and in-stent restenosis, what do I want to do to treat that in-stent restenosis? How's the best way for me to, what's the best tool in my arteriarium to treat that? So when I see it, like Art said, a lesion that may have one or two heavily calcified areas, I tend to use the Rotarex to aspirate as much as the thrombotic component, as much as the soft plaque component. And then at that point, if I need to treat that heavily calcified segment, I can get away with a short stent or get away with, rather than stent the whole thing. And so for me, that's another way that I use the Rotarex device is to kind of, what I do is especially I'll multiple passes, 8 passes through a single lesion, just to clear out as much of the thrombus or the soft plaque as possible. And then if the areas that, I just can't get to yield or I can't get for the Rotarex to actually debulk or do anything, then those segments I may treat with further. But again, our data has shown that, short little stents do much better than, a 30-centimeter, stented area. And so my practice has changed a lot in that segment that, whereas in the past, I would have probably used laser or jet stream. I find that the aspiration, the aspirational component, especially of the Rotarex, is able to clear a lot. And where, as opposed to, I would drip him overnight with lytics and bring him back and see the focal lesions that are caused, that initially caused the problems. I can do that quickly with the Rotarex and have similar effects as a long-term, as an overnight lysis. And so for me, that's how I kind of treat the thrombotic fibrotic lesions. For the calcified lesions, mostly mild to moderate, calcified lesions, I do well. If it's heavily calcified, and like a rock, or I felt like I went subintimal and then re-entered, I tend to not use the Rotarex in those areas, just because I think that, as far as the treating the severe calcium, it probably doesn't do as well. But as Art pointed out, I will treat above that lesion, I will take it past that lesion, and I'll treat below that lesion. And then if I have to come back, I can just treat that one segment.
Yeah, I think that's a great point. And, I really, the analogy with TPA is really good because, you give TPA and then you come back and there's these focal lesion or lesions. And that's what I find, I pass the Rotarex and all of a sudden there's areas that are wide open and then areas that are tight. And you get that, sort of debulking. And that's what I'm trying to achieve a lot of times when I use other atherectomy devices, sort of debulk and make room for the potential stent or DCB, right? And also, I think when you get out that thrombus, DCB works better when it's opposed to tissue, not thrombus. We don't know how well it works when there's thrombus between the wall of the artery and the DCB. So I think, when you put Rotarex down there and you get these areas that really clear out, and I'll show you some cases like that, I think that's really, really impressive. And that's part of the reason that I default to Rotarex unless there's a reason that I don't think it'll do well, like calcium.
One of the things I noticed that I always do, Art, is that I don't do is with, say, laser or Diamondback, is after laser or Diamondback, I never take a picture just after the atherectomy device.
Right.
But I find that after I Rotarex, before I do balloon angioplasty, that I always take a picture to see what I have there, because I felt like at that point, the atherectomy has actually done something.
Yeah, it's interesting because I do the same thing, but I do take pictures after Rotarex mainly because I'm a fairly new user. I mean, the last few months. So I kind of want to see it, but you're right. After Diamondback and Diamondback mostly, you don't usually see a result that matters, right? You're just modifying the plaque. With Rotarex, you definitely see a big change, like I'll show you some cases.
So there's a couple of questions here, Art. One was, what are the benefits of continuous aspiration? And the second is, prior to Rotarex, what was your typical algorithm for thrombotic lesions, DCB, stent, penumbra? Let me just talk a little bit about, let's not talk about continuous aspiration, because I think that that's probably impractical in terms of, true continuous aspiration. But I think that prior to Rotarex, I think most of us, what we did was we recognized thrombus. We would do some sort of, aspiration thrombectomy first, obviously with filter protection, followed by, some sort of atherectomy, and then obviously, aspiration of the filter and then remove it out. This is pretty much what we did at Sinai. But I think that's the paradigm that Rotarex has changed. I think that, having this device that really works well on thrombus and is able to aspirate as we go through, and it's not continuous aspiration. It's not like you're putting a penumbra into an iliac and turning it on. It's total, other than the 7 French new penumbra. The old penumbra was just a vacuum cleaner. This device truly affects thrombus, and it truly, is able to take out mixed morphology plaque. I think all three of us here, Ian, myself, and Art, would sit here and tell you that, we're not, ringing the bells for Rotarex. There's a lot of limitations to this particular device. One is sometimes, like Art said, you have to be very slow and your technique has to be very, very good. Second, if you're not, having aspiration, there are times we had to pull the device out and obviously suck it clean and then put it back in. It takes time. It's not something that you just put in, you got the Holy Grail in your hands and here we go, we're successful. But the point is that it really is effective if you take the time to use it. I think that's what Art was trying to say. It's like, it is a game changer in that sense. If you have massive thrombus and massive embolization, it's probably not the device. Art, I'm gonna let you build on that, and you too, Ian, but I think that that's kind of our take here.
Yeah, I'm probably a little more impressed with Rotarex, and it's, like I said, that's part of the reason I'm here. I used a lot of penumbra. I still love penumbra. I use a lot of it. I got to the point where I used a lot less filters because I knew that I had penumbra available to bail me out if I did it disembolize. But penumbra is amazing, but at the same time, probably it takes more time in a way because, you go in, you catch the thrombus, you got to pull it out, you got to go and cork it sometimes, you got to clear the system, so on and so forth. Now those same cases, I can put Rotarex down. There's 6 or 8 French if it's a big graft or something, and literally one pass. A lot of times I will completely clear it, and I haven't had to pull a penumbra after it to go chase any sort of distal embolization. But if I did distal embolize, I know that most of the time after Rotarex, the distal embolization will be very, very small ground up pieces because of the way the mechanism of the device works. And I always say I can have penumbra in as a bailout. But I haven't had to use that. So again, I really like it for these lesions. I think too calcified, what I would say is, it's all your experience. So I would start with the obviously thrombotic lesions or the mixed morphology and then push it, just like I'm doing right now. Like today's lesion, I was like, it's pretty calcified. I wasn't going to use a CSI because it was a total occlusion. I'm sure there was thrombus in there. So I put it in there and it actually performed very well. There was a point where it decelerated and kept decelerating. So I pulled it back and I actually withdrew the device and flushed it, and there was a big chunk of calcium that came through the system, and then we put it back in and repeated it. So I think, I can't tell you anything that's too calcified, but I would just try it, and then as you get more comfortable with it, push it to get your own experience.
Or just building on that is that these lesions with penumbra, you're not doing atherectomy. With Rotarex, you're doing both, which is really wonderful.
Yeah. And I wish I had this case that I did a vein graft that my partner dropped a TPA catheter on a Sunday or Saturday, maybe. Another partner of mine brought him back Monday and repositioned the catheter a little further down in the FemPop bypass graft. TPA for another 24, 36 hours. I got involved because I got called because the guy was bleeding overnight. So I brought him down and actually put an 8 French Rotarex device in, and so when I took the initial picture, no effect with the TPA, which was surprising, to be sure. I put 1 run of the Rotarex device, 8 French, and then because I was up and over, I couldn't reach all the way to the distal below knee anastomosis, so I took a 6 French below that and completely cleared the system. So I've been very, very impressed with the device in some of the worst cases.
I think PK makes the very important point of the between Rotarex and Penumbra is the Penumbra is just a thrombectomy device, whereas Rotarex has an atherectomy component, and does that atherectomy component does contribute to the mechanism of action for allowing for more aspiration and some of the more chronic thrombus that may be on the wall. One of the things that, as PK mentioned, sometimes you have to take it out and clean it out, but that's again because it's aspirating some chronic thrombus, some old fibrotic thrombus that that's what's causing a lot of problems, as in Art's case where he said the vein graft was occluded, and it's just usually some old thrombus that TPA just doesn't get into, doesn't affect. But the Rotarex, especially the 8 French, because it has so much aspirational power, can able to suck that out. And sometimes you have to take it out, clean it, and put it back in a couple more passes, and you have beautiful results. So I think from that standpoint, that's probably how I've changed my practice from doing in acute thrombus. Is I usually will try to Rotarex and see if I can get some aspiration out, get some plaque and old clot out, and then at that point see what I have left, and then kind of decide how I need to go. If one of the important points that I always keep in my mind is that even after Rotarex, if I'm going to balloon, say a stent that maybe I still feel there was something there and I don't want to put the Rotarex in again, or a vein graft, I put a filter down to protect myself. So, I think even after you use the Rotarex, if you're going to do balloon angioplasty and you're worried about embolization, you can put the filter down. There's nothing that says you can't, because you're using Rotarex, you can't put a filter down.
Yeah, that's a great point, and I do want to say this. I know it's not indicated; it's off-label. I spoke to the guys in Leipzig when we first got Rotarex approved in the U.S., and they use the EmboShield filter along with the Rotarex. So I think it's very important on a clinical basis for all of you to understand that it is possible to do the Rotarex on a filter. So it's not that you definitely need a filter in Rotarex, because the whole idea of Rotarex is that you do aspiration and thrombectomy at the same time. However, if you as a clinician feel that you need a filter, it's off-label, but you can do it just on our clinical experience. Next slide, Art, just so I don't beleaguer time, and I know I'm almost done here. Here are just some of the pluses and minuses of all the devices, and I think this is kind of nice, just to highlight the differences between all of them. As you can see, there are quite a few differences. If you can see, the Rotarex device is atherectomy and thrombectomy, as is the Jetstream, but none of the others are. Continuous active aspiration occurs in both Rotarex and Jetstream. Front debulking, again, occurs in those two, as well as the turbo power laser. Occlusions, obviously, these are indicated for occlusions and thrombus, especially Rotarex and Jetstream, and also in calcium, which the Diamondback and the Turbohawk are. So there is a good comparison. If you look at the Rotarex again, just a final summary, it's designed for multiple plaque morphologies, dual indicated for peripheral atherectomy and thrombectomy, a continuous active aspiration through large side windows, and definitely atraumatic and simple setup and use. Next. And I think, if you look at the clinical benefits, I think we've highlighted all that in our discussion. It's indicated for upper and lower peripheral arteries, 3 millimeters to 8 millimeters, acute, subacute, and chronic lesions, and again, atheroma and thrombus. It's basically, very important, I guess. I think the points that I want to really look at is the efficient aspiration. I think it's continuous, active, but as Ian and I mentioned, there may be some hiccups where you're going to have to be patient with the device. It minimizes embolization in all of our experiences for sure. And clearly, the internal mechanism, as Art said, breaks down the material as it's aspirated. So even if you embolize, it's very, very small material. It's not like this massive chunks that you get with different devices that you have to go suck out. So I think Art's point is very, very important. Next, please. And again, we went over this, so I'm just going to leave this out, and I'm not going to talk about ISR because generally it's off-label. Thanks, Art. Thanks, Ian.
PK, a couple of questions that were asked was, do you definitely not need a filter during Rotarex treatment? I think you point out eloquently that, it's off-label, but, we have personal experience, where we have put a filter down if we, while we Rotarex. It's not the normal, but if we felt that, that it's needed, then as an operator, it has been done and there's some experience doing that. And then the role of lithotripsy balloon in calcified lesions. Art, if you want to tackle that one.
That's, I think, a little off topic and we're running it short on time. So if we have time, we'll get to that at the end, but let me go through some cases, okay? But I do think it's obviously there's a role for it. All right, so just summarize, I'm gonna show you 4 cases if we have time, but this is a 76-year-old man who basically had this ulceration, some surgery that wasn't healing and had occlusion of his tibial vessels with very poor runoff. We thought he was a candidate for deep venous arterialization. For those of you who aren't familiar with that, that's where we go from the artery when there's no good conduit in the foot for bypass or any other option. We go from the artery into the vein. We stent from the artery into the vein, causing an AV fistula, and we force blood down into the foot via a venous conduit. And again, if anyone's interested, please get in touch with me. We're one of the trial sites in the United States. So here's the anatomy prior. You can see that the TP trunk is open, but really the AT and PT are out, and there's no flow in the foot. This is actually a moving video. You can see there's a hint of a dorsalis pedis, but when we went into ultrasound to that was not anything effective to revascularize. So this is a post-procedure. You can see the AV fistula going into the posterior tibial vein, which is covered stents into the foot, and you can see the venous flow into the foot. So we've had promising results in the trial called LimFlow. We saw him back right away. The wound looked better, more wet, something to work with, had debridement and closure. Unfortunately, the patient developed COVID and was hospitalized for several weeks. He missed an appointment. I tried to keep in touch with a podiatrist. They did some surgery, actually resected and closed it, and he seemed to be doing pretty well. So he came back to see me like 3 months later, and when I saw him, his graft had closed. And by best guess and pictures, we thought it had closed about 10 days prior. So we did an angiogram, and you can see the graft is now closed. Interestingly, the collateral flow to the foot looks better, which is one of the theories of doing this procedure. So we, with the advice of one of my friends who has more experience with Rotarex, he said, throw the Rotarex down there. So I actually brought him to our outpatient lab, not even inpatient, okay? So, not like a TPA hospitalization. Crossed fairly easily and advanced the Rotarex device easily through the stent. It cut to the point where I showed you there and it decelerated. So it was hitting something that was causing it to decelerate. So afterwards, you can see after one pass, okay, a slow pass, you can see that graft. And you can see there are areas of the graft that are wide open. You can see the filling there, okay? Now, when I ballooned it, you can see what caused that thrombosis is the restenosis in the vein at the distal margin, which is very calcified, very resistant. So you can see this is after balloon angioplasty, and great result and no evidence of distal embolization. So again, something where I can use this instead of penumbra in the outpatient lab, to be honest, at a more attractive price point, with probably better reimbursements, and patient goes home. And that was the stuff that we got. Now, remember, this is not the clot like in a penumbra. You get the whole clot sometimes, or a corked out portion. This is, ground up back in the bag, and it kind of accumulates. All right, so another guy who had, abnormal SFA duplex, claudication, but symptoms accelerating recently. So again, suspicious of a thrombotic event. We knew this was thrombotic because, again, he had an open SFA by ultrasound, a few weeks or months prior. So here we advance pretty easily, do Rotarex. And again, sometimes it's forward and back to let it breathe. If I don't hear it sort of decelerating, I'll just slowly advance it. You can see the stuff I got out of it. This is just after Rotarex, no balloon angioplasty. You can see there are areas that are wide open, okay? We didn't balloon those areas. So I think that's what we're talking about in terms of, some areas have stenosis, some areas are just clot or hybridating, areas. So this is after drug-coated balloon on the right. The left was just to show you the runoff after Rotarex. And you can see a very nice result. No new stent needed, no distal embolization. Third case, let's see, claudicant. Okay, so this is, a claudicant that had known disease for many years, actually, treated medically, but recently had accelerating symptoms. So we did an angiogram, and what we found was a profunda that was threatened. And that's what we thought was the cause of her accelerating symptoms. We actually stopped, recommended surgery, but she really didn't want to have surgery, didn't want to even have the consultation. So we brought her back and addressed the SFA. I forget if we addressed the profunda. We may have, to tell you the truth, but crossed it with relative ease. And you can see she had previous stents there. This is the runoff after I crossed. So we, again, slowly advanced the Rotarex device. I don't know why I don't have my pictures right afterwards, but used a 300 millimeter drug-coated balloon. And you can see a very nice result. No new stent needed. All right, so this is a long one. Oh, okay, this guy came in. So some of your questions about the acute limb ischemia. So this is a guy who came in, had known right popliteal disease that was moderate that I treated medically, came in with basically a cold leg while I was off, and my partner took him to the lab. He had the right popliteal artery that was newly occluded here. You can see the genicular collaterals on the right, filling the sort of the tibial bifurcation. And so during that case, he actually crossed, he used a penumbra device to do thrombectomy. He couldn't really expand the vessel because it was heavily calcified. So he actually used CSI on top of that, which I never do if I think there's clot, but he did. He ballooned it, and actually the right frame, I want to say, was his finished result. Okay, he had a dissection there, but he didn't think it was flow limiting, so he left it alone. Unfortunately, the patient came back fairly quickly with, pain that didn't resolve, tight stenosis on duplex residual. But by the time I came back and took care of him, the artery had already occluded, thrombosed off like 2 weeks later. So I came in and I rewired it with some difficulty. So there was definitely a dissection plane. I think my wire kept going in the dissection plane, but eventually wired it. I used one device this time, okay, that costs less than either of the 2 devices that he used, which in this case, it was the Rotarex. And let's see. Something is not right here. I don't know why the videos aren't playing. Okay, so sorry about that. Anyway, we got a good result. We expanded. We actually performed IVUS, and IVUS showed a lot of residual disease after balloon angioplasty, even though the angiogram looked good. So I aggressively dilated this, and it was a very large vessel. So we got to the point where we were able to put in a, I don't know why it's playing, superstent actually into the TP trunk, back into the popliteal artery, and got a very nice result, and his symptoms resolved, right away. All right, let's hope the next slides work. And then afterwards, I put him on rivaroxaban and aspirin instead. Okay, last case. Am I showing this case? Bilateral SFA occlusions. Okay, maybe this is a good example if it plays. Oh, something happened. I don't know why. Okay, I think, yeah, let's skip this case. So I think that's it. I mean, I think luckily you got a good, sample of cases showing the importance of that thrombus removal, debulking, which is something that we always want to do, especially when there's some constraining factor like a previous stent. I know that I can only expand that area so much. So again, debulking in those situations is what I try to obtain with other devices. With this device, I've had very good success going through it because of that chronic thrombus or acute thrombus or fibrotic plaque that it breaks up and sucks in. Had good debulking properties. So that's it for my presentation. And I think that's it for all 3 of us. So, we have a few minutes left. Do you guys have any questions? We'd love the interaction. Any comments by PK or Ian? Yeah.
Yeah, Art, I think, first of all, congratulations. Fantastic cases, as always. And I got to tell you that, I think you showed really clearly what myself and Ian were trying to, really describe on a theoretical level in terms of, how this device works. I mean, I think a couple of things really is you effectively demonstrated the effect on thrombus and really how much aspiration you get out of it. I actually sent Mason a photo, Mason Fote, who was supposed to join us today, a photo of this massive amount of clot that I was able to get out through a Rotarex device, similar to what you did in the vein graft. So I think the audience has to understand that, you know, this particular device, when used properly and in the right indication and in the right setting and in the right technique, really is quite effective. So I think I congratulate you on those cases. Great cases.
Yeah,
Yes, Art, wonderful cases. Good example of showing how it works. I think, you know, as PK mentioned, you know, technique is very important. And, you know, obviously your technique is very good to look at the results you got. But, you know, so I think that you mentioned, you know, you show a couple of off-label cases of ISR. You know, it works well in ISR. So I think that, you know, overall, you know, we talk about the thrombotic component, but it also works well on some of the fibrotic component.
Art, just before we go, since you just said recently you got your hands on it, for the audience, can you just go over, if I'm a new Rotarex user, say, you know, I'm a busy guy or gal and I'm doing atherectomy, I love atherectomy, and I want to start with Rotarex.
Yeah.
Tell me my lesion selection that I should start with, and go through the algorithm on your thought process as to how I should advance my experience with Rotarex.
All right, so I would say the best lesions to wow you, because we want to get you on board and be a believer, it's going to be the chronic total occlusions. Not necessarily acute. It doesn't have to be acute. If you have an acute limb, I would definitely use it. Okay, but if it's a chronic total occlusion SFA, not super calcified, you cross fairly easy, meaning, you know, you loop the wire. I use a vertebral catheter looped glide wire or a high wire, you know, hydrophilic wire 035 system, and I basically just push, you know, and I advance, and sometimes that just flies right through. In that case, I would exchange for the Rotarex wire, which is an 018 nitinol-based wire. You know, it's got good body to it. Advance that in, put in your system, usually 6 French at that point. And I would, it's fairly easy to use. I use the hand trigger, but there's a foot pedal if you want. I put one hand on the front of the device to advance it, and then the other hand, I hold the trigger. My tech is holding the wire. And at that point, I go forward slowly, slowly, slowly. If I hear it decelerate, I bring it back and I let it digest what it just hit. Because if you look at the model, you know, the front tip breaks it up, and if there's some clot, it kind of floats in the area, and then the action of the Archimedes screw basically sucks it in. So I let it breathe and I go forward. If I don't hear decelerate, then I basically go slowly forward all the way. And I ask the tech to hold the wire, and as I'm advancing, to move up with his hand or her hands on the wire. Before I hit the distal cap, I try to make sure I'm comfortable with the process. And sometimes I'll bring it back and let it sit there for a little bit, again, just to digest whatever's floating in that area. I use the distal cap almost as a distal protection device before I break through. Once I'm comfortable with that, then I break through. And then after that, I switch positions with the tech, and I hold the wire and I keep the button triggered. So it's aspirating as I'm pulling back. I aspirate all the way back until I'm about at the sheath. That's when I stop it and I pull it out. And then at that point, I take a picture and see what I'm left with. And it's been fairly good all the way through.
And having said that, Ian, just a question for you as Art went over this, which are the lesions that you would not make your first Rotarex case?
Heavily calcified lesions, anything that you felt like, especially in chronic total occlusions, that you felt you had to re-enter, you went subintimally. Those are the ones that I would not. If you think you're subintimal, this device probably doesn't work well. You should avoid it, at least if you still want to use it, avoid it in the subintimal areas. And obviously, if it's a hard rock and you had trouble, in our experience, we feel that you have to use the right device, the right tool for the right case. And if it's heavily calcified, Diamondback works better in that. That may be a place for a lithotripsy that someone asked earlier.
Yeah.
We're not, Rotarex, like you mentioned earlier, PK, is not the end all be all of atherectomy devices. I think the results we've had are really great and spectacular, but we've also been very good at selecting what lesions we tend to use it in.
Right. And Art, you mentioned about the OBL. And you and I both know OBLs have become a more commonplace of treating PAD. So cost effectiveness, you did mention that a few times, and we got a question on that, and I just want to go over that. Is Rotarex a cost effective option in the OBL setting? And I know you work there. I don't know if Ian does. What is the lowdown on that?
Yeah, no, I think it's very cost effective. And again, it depends on what your definition of cost effectiveness. It's clearly the device pays for itself and more. It potentially, in certain cases, is doing thrombectomy, mechanical thrombectomy, and atherectomy. Although I think in most cases we're not billing both, but some cases we are. And the cost of the device is less than the penumbra, I would say. Again, it depends on what your the contract says, but the penumbra has the device itself, and then it also has the separator wire. And if you add that, I don't want to spit out the wrong numbers here, but it's significantly less than using both of those. So I think it's very, very favorable in that regards. But ultimately, like you said, the most important thing is the patient outcomes, right? Not prolonging the case. The two things that work really badly in the outpatient lab are unsuccessful procedures and complications, right? In distal embolizations, where you're extending the length of the procedure. Those are bad things from a financial standpoint in an outpatient lab. So again, I think this device is a really nice device to avoid those things, if that makes sense.
Makes perfect sense, buddy. And I think it's important because Ian pointed out in his talk, as we have to consider, radiation to the patient, dye to the patient, duration of the procedure, and also, systematically the cost of the procedure, not only to say an OBL, but also to a hospital system and to general healthcare overall. So if we can identify the right patient for the right product and the right lesion for the most effective outcome, I think that we've achieved a lot.
Yeah.
One of the things I did initially to get it approved in our lab is we had an acute limb from aortofem, again off-label, guys. So we had a little experience with it. But someone that we would lyse overnight or lyse for a couple of days, but we used the Rotarex and got great results. And I just simply sent it to my hospital administrator. Said, "How much money do we save?" We got great outcome, great patient outcome. In fact, we decreased the likelihood of them having some complication from getting lysis, and the hospital still didn't, have to keep them over 2 to 3 days just to lyse them. So yeah. I think, in that sense, it's a good cost-effective way, even for the hospital system.
Yeah, and I said previously, I'm a heavy penumbra user. I believe in that versus TPA 90% of the cases. I can tell you the 8 French device, 7 French device penumbra are very good. The 6 French device is not that great. It's very delicate, going through the little check flow valve, especially the Cook sheets are very tight. It's very delicate. It doesn't give you the best results. I've used the 8 French and 6 French device Rotarex. 8 French clearly in a graft is great, but I can tell you the workhorse for us is 6 French. And I think the 6 French Rotarex definitely works better than the 6 French penumbra, especially in the outpatient lab setting for us.
That's great insight.
Yeah.
There's another question here that just came through, which I think, I know you do a lot of this as, and I don't know if you do it in the OBL, pedal access and the Rotarex. In terms of primary, interventions.
Yeah. So, and the question before that, I just saw, I didn't realize it was Rotarex still cost effective. So yeah, clearly it's cost effective in the outpatient lab, and you can get in touch with me and I can do one-on-ones with you guys about that. Yes, I have used it from pedal access, not a whole bunch because again, I'm fairly new to it, but it's fine. If you have a 5'6" slender is what I typically use. If I needed it, I try to keep it as small as possible. But if there's a case where I really want to use it and I'm 5'6", then yeah, you can definitely use it from a retrograde standpoint. Really nothing about it that, is a big deal. I would say even more important in that situation is before you pop through the proximal cap is to really make sure that you clear that system, because remember, once you open that, you have inflow pushing all the debris distal, and maybe the Rotarex theoretically won't catch it all or won't have time. But at the same time, at that point, you have a 5'6" French sheath in the distal tibial. So what I do is I let it bleed out, and whatever debris is going to just sort of, go out of the sheath as opposed to into the foot.
I agree with Art. I've done several cases from pedal access. My only concerns ever are sometimes going around the AT origin into the popliteal just because of the bias sometimes. And then if there's any heavy calcification sometimes in the tibials where I'm worried about the size or crossing through that. But usually the atherectomy segment of the Rotarex usually works well in that. But be mindful again that it's only indicated for vessels 3 millimeters or above.
Right.
Yeah, well, we've never done typical, Rotarex. Just don't see the need for it. But I guess obviously anything is, if it's indicated or if you feel you can do it with a large enough vessel, I definitely don't see any reason why not to.
Yeah, I think it's getting a little more advanced discussion. And again, I hope to get more experience with this, but I think Popliteal is great. This Popliteal is fine. Proximal tibial vessels that are 3 millimeters or more, I think you're okay using it. Just be careful with like AT takeoffs because again, because of wire bias and so on and so forth, when that device goes around where the AT comes off, theoretically you can sort of, as those devices spinning, you can sort of engage the carina of the AT and TP trunk. So that's an area that I would not activate the device when I'm crossing. I would get it into the AT and then activate it, but probably better in the FemPop segment, especially in the beginning. All right, I think that really we've taken up our time and a little bit more. If there's any, maybe one or two more questions, but I think we've reached the end of the program tonight. So while I wait for any questions, I want to thank NACME for putting this on and BD for the educational grant. Obviously, I want to thank my friends Ian and Prakash. Good seeing you guys online and great discussion and education. Any other comments while I read this question?
It says here, I recently used the Rotarex device to revascularize a subacutely ischemic leg 3 days or so in a patient that thrombosed his supera SFA P1, P2 stents. The entire SFA pop was thrombosed. 2 passes resulted in excellent flow. I needed to treat 2 short segments, like Ian had pointed out, with cutting and drug-coated balloon. Awesome device, complete success. I guess echoing kind of what all of us said today, but great case, guys.
That's a perfect way to end this webcast, I think. All right. Well, okay. Well, thank you guys for joining us. And again, thank you to everybody out there. And thanks to our panel here. We hope you have a safe and, great night, and hope to see you again on a webcast or live at a meeting.
Thank you again.
Okay.
Thank you.
Thanks, guys.